Welcome to eNormous Nephrology. This is volume 7 of a board review series comprising of 8 volumes. In board review series volume number 6, we discussed nephritic syndromes including IgA nephropathy, lupus nephritis, ANCA vasculitis, and some other glomerulonephritides. In this volume, board review volume number 7, we will discuss the remaining nephritic syndromes, including MPGN and post-infectious glomerulonephritis. Now, MPGN is a big topic. It's a broad topic, including autoimmune diseases, C3GN, dense deposit disease, and even thrombotic microangiopathy. So this will be an exciting talk. All of my talks will be housed at youtube.com/@irfan-moinuddin-kidney. Let's begin. As the title Membranoproliferative Glomerulonephritis suggests, MPGN is an inflammatory process, hence glomerulonephritis, inflammation of the glomerulus. And it involves two main things: structural changes and damage to the glomerular basement membrane and proliferation. And that proliferation can be mesangial proliferation or endocapillary proliferation. And there's usually lobulation. Damage to the glomerular basement membrane manifests as double contour, also known as tram tracking, and thickening of the glomerular basement membrane. This is a normal glomerulus, just to remind you what a normal glomerulus looks like. And a lot of the definitions of kidney biopsy components that you'll see on biopsy reports have been defined in Board Review 5. So this is a normal glomerulus. The white stuff that you see there are open capillaries. So the capillary lumens are empty, not filled with inflammatory cells. And then the pink stuff is the glue that holds the glomerulus together. That's the mesangium. And the mesangium should not be hypercellular. And by hypercellular, we mean more than 4 cells in any contiguous portion of the mesangium. This is a glomerulus with lots of proliferation. As you can see, all the capillary loops are full of inflammatory cells. You cannot see any of the lumens, which would be white on this H&E stain. And the mesangium is also proliferating. As you can see here in this contiguous area of mesangium, there are definitely more than 4 cells. So mesangial hypercellularity is defined as more than 4 nuclei in a contiguous matrix of a mesangial segment. And endocapillary hypercellularity is when cell aggregates fill the capillary lumen. This is just an example of double contour, also known as tram tracking. And by tram tracking, we are referring to train tracks. As you know, there are 2 parallel lines upon which the train runs. So double contour looks like a train track because you have the original basement membrane, which is injured, and the cell makes another basement membrane trying to protect itself. And we'll talk about the reason why tram tracking or double contouring happens in subsequent slides. So MPGN is what you see on light microscopy. You see glomerular basement membrane thickening, double contouring, mesangial proliferation, endocapillary proliferation. But MPGN is basically a pattern. Just like membranous nephropathy, FSGS, full house, these are all biopsy patterns that we see when we look under the microscope. Those patterns are then correlated with clinical scenarios, clinical presentations, clinical diagnoses. And that's how we know that a particular pattern can mean this particular etiology. So MPGN has a big differential. So how do you make sense of all the different causes that can lead to an MPGN pattern? So obviously attempts were made to classify these etiologies. The older classification was based on electron microscopy. But it was non-intuitive and it didn't really take into account the underlying pathophysiology. The newer or current classification is based on immunofluorescence. So you diagnose an MPGN pattern based on light microscopy, and then you look at the immunofluorescence. Is the IF staining for immunoglobulin? If so, then it could be from infections and immune complex disease, neoplastic or other etiologies. Do you see complement deposition, but not immunoglobulin deposition? Then in that scenario, you would consider C3 glomerulonephritis or dense deposit disease. Or you could have a immunofluorescence without staining for either immunoglobulins or complements. In that scenario, you should be thinking about thrombotic microangiopathy or complement-mediated thrombotic microangiopathy. And we'll talk about the whole differential in subsequent slides. So on the basis of immunofluorescence, to summarize everything, you can have C3 glomerulonephritis or dense deposit disease. If you have complement staining on immunofluorescence, but not Ig immunoglobulins. If you have immunoglobulin with or without complement, then you should consider infection, autoimmune disease, or monoclonal gammopathy. And if it's immunofluorescence negative, meaning it doesn't stain for either immunoglobulin or complement, then you should consider complement-mediated thrombotic microangiopathy. So C3 glomerulopathy is a rare disease with an estimated prevalence of 5 cases per 1 million in the United States. So we do make a distinction between C3 glomerulopathy and C3 glomerulonephritis. So C3 glomerulonephritis and dense deposit disease are two subtypes of C3 glomerulopathy, and they result from dysregulation of the alternate complement pathway. And because there's dysregulation of the alternate complement pathway, C3 is low, but C4 is typically normal. You can develop C3 glomerulopathy because of autoantibodies, so it can be acquired, or because of inherited genetic abnormalities in complement-related genes. It manifests with hematuria, proteinuria, reduced kidney function, and hypertension, and about 30% may present with nephrotic syndrome. Let's talk about prognosis. So in a Columbia University cohort of 111 patients with C3 glomerulopathy, there was a follow-up period of about 72 months. 38% of patients with C3GN and 25% of patients with dense deposit disease developed a remission. Patients with C3GN, 39.1% of C3GN and 41.7% of dense deposit disease progressed to a combined outcome, i.e. doubling of creatinine, CKD stage 5, end-stage renal disease, or death. So both subtypes kind of showed a similar clinical course. Rarely, C3 glomerulopathy can present with severe necrotizing and crescentic GN. Non-renal manifestations of C3 glomerulopathy include acquired partial lipodystrophy that's localized to the upper half of the body, which can be present before the renal manifestations, and drusen, which are extracellular deposits between the Bruch membrane and the retinal pigment epithelium. This is an early sign of age-related macular degeneration and can be found in patients with C3 glomerulopathy in early adulthood. So light microscopy displays an MPGN pattern, and immunofluorescence shows a dominant C3 staining that is at least 2 orders of magnitude greater than any other immune reactants. Ig deposits are typically absent or scant. Electron microscopy is used to divide C3 glomerulopathy into C3 GN and dense deposit disease. Dense deposit disease has dense osmophilic intramembranous deposits, and C3 GN has light amorphous mesangial, paramesangial, subendothelial, and or subepithelial deposits. So we were talking about double contouring. Why does double contouring or tram tracking happen? Because the mesangial cell has a macrophage-like function. So it's to some extent the mesangial cell is a macrophage. So it tries to phagocytize immune complexes. Now, it tries to phagocytize the immune complex, but in the process it injures the glomerular basement membrane. So mesangial cytoplasm is interposed into the basement membrane, causing splitting and reduplication of the glomerular basement membrane. Dense deposit disease is relatively easy to spot. These are these dense deposits in the subendothelial location that are very characteristic of dense deposit disease. It can be difficult to exclude post-infectious glomerulonephritis in some cases. Post-infectious GN typically has a diffuse proliferative lesion on light microscopy with codominant staining of C3 and IgG. And as we said, in C3 glomerulopathy, C3 is much more intense than any other stain. But C3 staining is sometimes of greater intensity than IgG in post-infectious GN. So the differential does need to be considered, and infection-related GN may be a strong consideration in some cases. Isolated C3 without IgG may also be observed, mimicking C3 glomerulopathy. So how do you differentiate between the two? On the basis of biopsy alone, it can be very challenging. But post-infectious glomerulonephritis may be suspected at initial presentation. I would say should be suspected on initial presentation if there is a infectious etiology which seems to correlate. The clinical manifestation of post-infectious GN generally resolve within 8 weeks. And if there's persistent renal dysfunction, proteinuria, hematuria, and hypocomplementemia beyond 12 weeks, then C3GN should be entertained. So C3 glomerulopathy is caused by a dysregulation of the alternate complement pathway. Excessive activation of the alternate complement pathway is prevented by regulatory proteins such as complement factor I or complement factor H and other proteins. Mutations in these factors or genetic rearrangement causes dysregulation and overall activation of the alternate pathway. So potential therapies with recombinant factor H or a recombinant complement receptor of the Ig superfamily are being studied. Acquired forms of the disease account for the largest fraction of cases. And this is generally due to generation of autoantibodies to components of the alternative pathway, resulting in excessive activation. For example, the C3 and C5 nephritic factors are autoantibodies that stabilize the C3 and C5 convertases respectively. Autoantibodies to CFH impair its inhibitory function on the alternative pathway, and patients with monoclonal gammopathy or multiple myeloma may generate antibody fragments or intact antibodies that interfere with alternate pathway regulation. In a patient with C3 glomerulopathy, one should test complements, SPEP with immunofixation, and three serum-free light chains. Some complement biomarkers may be available at your institution. Generally, you should do antibody testing for C3 nephritic factor, C4 nephritic factor, C5 nephritic factor, factor H autoantibody, and factor B autoantibody. Some of these assays may not be available in all centers, and a search for monoclonal gammopathy should be considered in patients older than 50 years, and genetic testing should be considered, particularly in familial forms of disease. RAS inhibition is appropriate. Plasma infusion may supply a deficient complement inhibitor. Plasma exchange may remove autoantibodies that activate the alternate complement pathway. Um, the true utility of this approach in C3 glomerulopathy is actually unknown. Eculizumab blocks C5, preventing its cleavage into C5a and C5b, and prevents formation of the membrane attack complex. Less than half of the patients responded to eculizumab with reductions in proteinuria or creatinine level. Ravulizumab is a humanized monoclonal antibody agent against C5. It has a longer half-life and requires dosing every 8 weeks. Patients with C3 glomerulopathy treated with mycophenolate, 1 gram twice a day for at least 3 months, and steroids, 67% achieved complete or partial remission. This was a study at Columbia University. So according to KDIGO 2021, in the absence of monoclonal gammopathy, severe C3 glomerulopathy should be treated initially with mycophenolate mofetil and glucocorticoids with eculizumab as a second-line agent if needed. Iptacopan, or Fabhalta, is an FDA-approved first in-class oral medication that selectively targets factor B to inhibit the alternate complement pathway. It's designed to slow the progression of C3 glomerulopathy by reducing proteinuria, normalizing serum C3 levels, and preventing glomerular C3 deposition. Empaveli is an FDA-approved C3 complement inhibitor. It reduces proteinuria by over 68% and stabilizes kidney function in C3 glomerulopathy and immune complex MPGN. Monoclonal gammopathy of renal significance can be classified based on the presence or absence of monoclonal immunoglobulin deposition in the kidney. Lesions that are not associated with deposits include monoclonal gammopathy-associated C3G and thrombotic microangiopathy. Monoclonal proteins activate the alternative complement pathway by binding to factor H. 30% of patients with C3 glomerulopathy actually have a monoclonal gammopathy. C3 nephritic factor is detected in about 50% of these patients. Genetic inherited abnormalities are quite rare. One should rule out the presence of masked monotypic staining, which means that if you do specialized staining at specialized pathology centers, you may unmask the monotypic staining and treatment slightly changes. If you have monoclonal gammopathy associated C3 glomerulopathy with monoclonal deposits, then you have to treat it like an immune complex deposition disease. So you would treat with proteasome inhibitors such as bortezomib and anti-CD38 monoclonal antibodies um, in either case. But if you have um, deposits, immune complex deposits or monoclonal deposits, then you will also use treatments such as mycophenolate and steroids. Recurrent C3 glomerulopathy after kidney transplantation is very common. Graft failure is a frequent occurrence. Um, and patients with a primary diagnosis of MPGN had significantly poorer patient and allograft survival rates when compared to other forms of primary glomerulonephritis. Let's talk about complement-mediated TMA. This was previously known as atypical hemolytic uremic syndrome. TMA, complement-mediated TMA, can be inherited or acquired, and it can be triggered by infections, vaccinations, drugs, or pregnancy. It will present with thrombocytopenia and microangiopathic hemolytic anemia, low haptoglobin, increased reticulocyte count, and LDH. Absence of thrombocytopenia does not rule out renal-limited TMA. You can have TMA that is limited to the kidney and that does not have any manifestations in the peripheral blood. Low C3 level may be present in about 30 to 50% of cases. Kidney involvement is common with hematuria, proteinuria, acute kidney injury, chronic kidney disease, and hypertension. Pregnancy-associated thrombotic microangiopathy is usually initially diagnosed as preeclampsia or HELP syndrome. 27% experience progression to end-stage renal disease. In 10 patients who were treated with eculizumab, none experienced end-stage renal disease. And in 12 patients who were not treated with eculizumab, 6 patients reached end-stage renal disease. About 50% of patients with complement-mediated thrombotic microangiopathy have a recognizable hereditary and/or acquired complement abnormality. The acquired forms are associated with anti-CFH antibodies, which dysregulate the alternative complement pathway. These are almost always homozygous for a common deletion in complement regulatory proteins CFHR3 and CFHR1. Genetic forms are caused by mutations in regulatory factors that act in the circulation or at the cell surface. Gain-of-function mutations in C3 and factor B can also cause complement-mediated hemolytic uremic syndrome. Finally, mutations in diacylglycerol kinase epsilon also cause complement-mediated TMA. So kidney biopsy is going to show a thrombotic microangiopathy pattern of injury. And we said that it would not stain, immunofluorescence would not stain for IgG or complement. So if this is complement mediated, why doesn't it stain for complement? And the answer is that complement is activated in the circulating blood or locally on the endothelial cell surface, and then the terminal complement components, such as the membrane attack complex, cause direct damage and are then washed away in the bloodstream rather than depositing visibly in the vessel walls. So this is not an immune complex deposition disease. This is because of damage caused by the membrane attack complex. Ultimately, it is because of uh, activation of the alternate complement pathway. Um, Again, classic antigen-antibody complexes do not form, so Ig is not stained either. You are going to see thrombosis with intraluminal fibrin or fibrin platelet plugging, endothelial swelling and denudation, mesangiolisis, Of course, duplication of the glomerular basement membranes, which is the double contouring or tram tracking, and arteries and arterioles show onion skinning pattern. Before assuming that this is complement-mediated thrombotic microangiopathy, you should exclude other causes of TMA, including malignant hypertension. This is a very common cause of thrombotic microangiopathy, and malignant hypertension frequently causes renal-limited TMA, so you may not see any changes in the peripheral blood. Shiga toxin-producing or E. coli-associated hemolytic uremic syndrome should be excluded. TTP, which is because of ADAMTS deficiency, drug-induced TMA, infection-induced TMA, autoimmune disease-induced TMA, or pregnancy-induced TMA. So this is a busy slide, but essentially the most important thing is that eculizumab is an effective treatment for complement-mediated TMA. It works by binding to the complement protein C5 and preventing its cleavage into C5a and C5b and preventing formation of the membrane attack complex. Improves thrombocytopenia and kidney function in patients with complement-mediated TMA. It does require preventative measures against meningococcal infection, and patients should take the quadrivalent and serogroup B meningococcal vaccine at least 2 weeks prior to the first dose of eculizumab and take prophylactic antibiotics such as penicillin VK or erythromycin. Eculizumab has been used safely in pregnancy. There is a reported 30% recurrence rate after eculizumab discontinuation. But KDIGO does recommend discontinuation of complement inhibitor after at least 6 to 12 months of treatment and at least 3 months of stabilization of kidney function. In cases of dialysis-dependent acute kidney injury, eculizumab should be continued for at least 4 to 6 months of treatment due to the chance of late renal recovery. Periodic close monitoring of kidney function and hematologic parameters is mandatory. In kidney transplantation, discontinuation is not recommended. Transplantation should be delayed until at least 6 months after the initiation of dialysis. Prophylactic eculizumab can be used if risk of recurrence is high. Ravulizumab, like we said, is a long-acting humanized monoclonal antibody agent against C5, has an extended half-life and can be dosed every 8 weeks. Then we will go on to discuss infection-related glomerulonephritis. So we'll talk about viral infections, hepatitis C, and then bacterial infections, prognosis of infection-related glomerulonephritis, and pathogenic mechanisms. Let's talk about HIVAN, HIV-associated nephropathy. This is frequently nephrotic, but will be discussed here in volume 7. Expression of HIV genes, specifically Neph and VPR, leads to podocyte dedifferentiation and proliferation, resulting in collapsing glomerulopathy. HIVAN is an ApoL1-related kidney disease, and because high-risk ApoL1 genotypes are found most abundantly in patients with sub-Saharan African ancestry, it makes sense that the incidence of HIVAN is drastically higher in patients of West African descent. ApoL1 high-risk genotype is strongly associated with the risk of CKD progression and end-stage renal disease of HIV-infected individuals. However, the ApoL1 genotype did not predict the severity of histologic findings in patients with HIVAN, nor was genotype alone able to predict biopsy findings in patients with HIV and kidney disease. ApoL1 is also a risk factor for non-HIVAN FSGS occurring in patients with HIV. So effective antiretroviral therapy has changed the landscape of HIV-associated kidney injury. And this becomes very obvious and dramatic when you notice that in a biopsy study from Colombia from 1987, the report was that HIVAN was found in 76% of biopsies from a young HIV-infected population. In 2020, a retrospective biopsy review from the same institution reported results of 437 HIV-positive individuals who underwent biopsy, and only 14% had HIVAN. The rest had other etiologies. So if antiretroviral therapy is the mainstay of treatment for HIVAN, and KDIGO does recommend that certain agents are ideally avoided because of nephrotoxicity, including isoproxyl fumarate, atazanavir, and lopinavir/ritonavir. ACE/ARBs should be used in patients with HIV and hypertension. Steroids should be avoided. There's lack of evidence that they slow progression to end-stage renal disease. There is clear survival advantage with kidney transplantation compared to remaining on dialysis. And kidney transplant outcomes are comparable to HIV negative patients. Rejection rates may be slightly higher. An effective antiretroviral therapy, HIV viral loads remain controlled despite transplant immunosuppression. And the added advantage is that you can utilize HIV-infected kidney donors for HIV-infected kidney transplant recipients, thereby markedly increasing the donor pool and shortening the waitlist times for HIV-infected patients with end-stage renal disease. HIVIC, or HIV-associated immune complex kidney diseases, was a term that was used frequently in the recent past, was quite popular actually, but that term is discouraged because immune complex disease occurs in patients with undetectable viral loads. So it may not necessarily be HIV associated. There may be other reasons for having immune complex kidney disease in HIV patients. So use the term immune complex disease in the setting of HIV. Immune complex glomerular diseases that occur in patients with HIV include cryoglobulonemic glomerulonephritis, IgA nephropathy, post-infectious GN, membranous glomerulopathy, fibrillary GN, immunotactoid glomerulopathy, and lupus-like glomerulonephritis. The workup is the same as in other immune complex diseases. For example, check PLA2R in membranous nephropathy. Antiretroviral therapy does not decrease the risk of progression of immune complex mediated diseases. Thus, in patients with well-controlled HIV infection, immunosuppressive treatment of the immune complex mediated glomerular disease should follow the same guidelines as for patients without HIV infection. Now let's talk about hepatitis C. Hepatitis C causes cirrhosis and hepatocellular carcinoma. Extrahepatic manifestations include cryo, which is the most common. Other glomerular diseases, including Membranoproliferative GN, membranous nephropathy, fibrillary GN, immunotactoid glomerulopathy, and IgA nephropathy, have been associated with chronic hepatitis C viral infection, but causality or association is not well understood. Cryoglobulins are circulating proteins that precipitate below core body temperature and dissolve upon rewarming. Cryoglobulins may be detected in up to 50% of patients with chronic hepatitis C viral infection, but only 2 to 3% of patients develop vasculitic symptoms. Presentation is palpable purpura, arthralgia, neuropathy, and GN. Cryoglobulonemic GN findings include hypertension, proteinuria, microscopic hematuria, and renal insufficiency. A minority may develop nephrotic syndrome, about 20%, or rapidly progressive glomerulonephritis, about 10%. Most patients with cryo have a positive rheumatoid factor and low C4. C4 is cryoprecipitable, so you would expect that C4 would be low because it would precipitate. Membranoproliferative pattern of GN is found in cryoglobulonemic GN. There's deposition of mesangial and subendothelial immune complexes, leading to subendothelial proliferation and glomerular basement membrane thickening. Pseudothrombi are large, eosinophilic, intraglomerular, periodic acid shift stain positive deposits. Immunofluorescence staining confirms mesangial and capillary wall deposition of IgM, IgG, and C3. Hepatitis C virus-associated mixed cryoglobulinemia syndrome should be treated with the goal to cure the symptoms of the mixed cryoglobulinemia and to eliminate hepatitis C virus infection. Hepatitis C is curable. In fact, cure rate is greater than 98% even in immunosuppressed patients with HIV or solid organ transplants. KDIGO guidelines recommend that direct-acting antiviral agents be used alone as first-line therapy in patients with cryo. Rituximab and steroids plus or minus plasmapheresis should only be used concurrently with direct-acting antiviral agents in patients who present with 1. RPGN, 2. Severe systemic vasculitis, including CNS involvement or pulmonary hemorrhage, or 3. Symptomatic nephrotic syndrome. Immunosuppressive therapy should be used in patients who have histologically active hepatitis C virus-associated glomerular disease who do not respond to antiviral therapy alone. De novo cryo and other GNs can occur in patients after hepatitis C virus infection has been cured, and these patients should also receive immunosuppression. Hepatitis B virus is a major cause of chronic liver disease and hepatocellular carcinoma worldwide, but hepatitis B-related disease is very rare in parts of the world that have effective vaccination strategies. Hepatitis B virus-associated renal diseases include secondary membranous nephropathy, polyarthritis nodosa, and less commonly MPGN, IgA nephropathy, minimal change disease, and FSGS. Unlike primary membranous nephropathy, secondary membranous nephropathy caused by hepatitis B is unlikely to remit spontaneously. Immediate antiviral treatment is recommended. Virologic response has been shown in some studies to correlate with long-term resolution of proteinuria. Tacrolimus has been used successfully, but immunosuppression may cause induction of hepatitis B viral replication and may cause liver or kidney damage. Polyarthritis nodosa causes inflammation and necrosis of arterial walls of medium and small-sized arteries. Microaneurysms and organ infarcts are common. Polyarthritis nodosa can manifest as malignant hypertension with mild proteinuria hematuria to acute kidney injury from kidney hemorrhage or infarct. Corticosteroid therapy and plasma exchange are used initially to control the most severe life-threatening manifestations of polyarthritis nodosa. Subsequently, corticosteroid treatment is discontinued after 2 weeks to enhance the ability of effective antiviral therapy to clear hepatitis B from infected hepatocytes, allowing seroconversion of HBe antigen to anti-HBe antibody. Even after resolution of symptoms of polyarthritis nodosa, a durable virologic response to HBV treatment is of utmost importance in order to avoid polyarthritis nodosa relapse. Let's talk about bacterial infections and glomerulonephritis. So we usually talk about staphylococcal associated glomerulonephritis, but of course any bacterial infection, including infective endocarditis and streptococcus can cause post-infectious glomerulonephritis. And here, so there are three etiologies which can mimic each other and need to be dissected and separated in the clinical setting, and to ensure that correct treatment is being implemented. IgA nephropathy generally has normal complements. Post-infectious GN will have low complement, which will normalize after appropriately treated infection. And C3GN will have persistently low C3 levels. IgA nephropathy mainly displays mesangial proliferative disease, and post-infectious GN shows diffuse endocapillary exudative features and large hump-shaped deposits in the subepithelial location. This is very classic, the large hump-shaped deposits in the subepithelial location. C3GN will show a membranoproliferative pattern of injury, and mesangial and subendothelial or intramembranous deposits. As far as immunofluorescence, IgA nephropathy usually has strong IgA staining, and it's very atypical to have strong C3 staining. Post-infectious GN will have strong C3 staining, but also codominant IgG staining. And then C3 glomerulopathy, it will be C3 staining is the strongest, and others are much less prominent. IgA nephropathy rarely presents with severe AKI and is typically slowly progressive over many years. Post-infectious is a common cause of acute GN and can present with severe acute kidney injury, but with treatment can resolve very fast. C3GN can present with severe acute kidney injury and usually has persistent or recurrent glomerulonephritis. Treatment of post-infectious GN should focus on antimicrobial therapy to eliminate the infection. Corticosteroid therapy does not improve kidney outcomes for patients with infection-associated GN. Post-streptococcal GN is common in children but rare in adults. The streptococcal pyogenic exotoxin B binds directly to the glomerulobasal membrane, and streptococcal antigens activate complement through the alternative or lectin pathway. Post-strep GN may behave like asymptomatic hematuria or cause progressive glomerulonephritis. Histology is the same as post-staphylococcal GN. Treatment is focused on eradicating streptococcal infection with penicillin, or an alternative if the patient is penicillin allergic. In most cases, there's complete recovery of kidney function within a few days to weeks after resolution of the infection. Post-strep GN does not recur. Patients whose GN does not resolve or whose complement levels do not normalize with treatment may have C3 glomerulopathy. And we've arrived at the end of Board Review Volume 7. The next volume, or Volume 8, will be the last volume of the Board Review series. And in it, we will discuss nephrotic syndromes. And that will complete the Board Review series. Check out my YouTube channel, eNormous Nephrology, at youtube.com/@irfanmoindeen-kidney. There are lots of articles on many topics, including a hypertension series, polycystic kidneys, and many other requested topics from viewers. Thanks a lot. See you next time.